Thank you, Professor Siebenreich, for having me back again. So I'm going to talk about the role of arthroscopy for instability. So bear with me here. So instability patterns, which of them are amenable to arthroscopy? So similar to what Moritz was talking about, I'm going to talk about sort of the way I evaluate this. So we have FAI CAM-induced traumatic instability, which you've heard about. We have soft tissue laxity, hypermobility. We have high range of motion impingement-induced instability, and you can kind of lump those two together. And then we'll talk a little bit about mild osseous dysplasia, borderline dysplasia, whatever we want to call it, mild instability. So FAI, CAM-induced traumatic instability, you've heard about that. So typically you have this anterior cam that can lever against the anterior rim, resulting in a posterior subluxation or dislocation. Some of you have seen this. So there's a wrestler you can see as he dislocates his hip posteriorly as he's kind of torquing around, and he has a large anteriorly based cam, so you don't oftentimes get these on a video, and you can see the guy just writhing there. I'll just keep showing it because I know you're all loving that. Anatomy and treatment. Typically, again, there's a large cam deformity, and as Professor Siebenreich and the Bern group here has shown, a retroverted acetabulum, and I think that retroverted acetabulum allows for a posterior escape. There's definitely a low risk for AVN, but you may want to consider an MRI at 6 to 12 weeks if there is a dislocation or subluxation. Typically, in my practice, surgery is reserved for persistent symptoms unless they have an incongruent reduction, loose bodies, or a large posterior rim fracture. If we look at surgical treatment, my approach may be a little different. I would consider a femoral resection to reduce the anterior levering instability arthroscopically, repair the labrum. Typically there's anterior and posterior labral tears, a capsular plication or repair. If there is a posterior rim fracture, if present, they're typically small and stable at the time of surgery. A couple of studies, there's just an example of the femoral resection arthroscopically. This is a study that we published with Brian Kelly, Tom Bird, looking at 22 athletes that had a history of traumatic instability, a posterior rim fracture. 82% had large cam-type FAI. Only half of them required surgery. They were all done arthroscopically. At mean 4-year follow-up, the modified Harris hip was 94. The Bern group has also looked at this. They looked at 53 hips who had a previous posterior hip dislocation, which you heard earlier, compared to 85 normals. Again, seeing that those with a posterior dislocation had a higher prevalence of an anterior cam deformity and a retroverted acetabulum, and they proposed the same thing with an anterior fulcrum provided by the anterior cam and a retroverted acetabulum that might account for this increased risk of posterior dislocation. So what about this? This is a little bit of a quandary. Soft tissue laxity, hypermobility, a high range of motion, impingement-induced instability, and you're going to hear about this in the next talk as well. So capsular laxity is seen most frequently in females. Generalized hypermobility syndrome, you want to be familiar with Bateman's criteria. Extreme example would be a connective tissue disorder, such as Ehlers-Danlos syndrome. They oftentimes have globally increased range of motion and more than you might expect based on their radiographic or imaging studies. They may have giveaway instability or giveaway sensations despite plain radiographs and CT scans looking stable. At least intraoperatively, if you see these findings, you want to think about instability. So an easily distractible hip under fluoroscopy. After venting the capsule, you see this increased capsular volume. But I think look at everything. Look at how the ankle moves when you put it into the boot. Look at your skin incision. It's almost like slicing through butter. There's very distinct, there's a very distinct kind of tactile sensation to this. The capsular resistance upon entry into the joint, sometimes it's very little resistance or you don't feel it at all. And then capsular laxity or redundancy, where you have this seeing too much sign. Before you've even made a capsulotomy, you can see everything. So all of these lean towards instability. And then even a normal or a dysplastic hip can impinge with extreme range of motion activities. We see this in activities such as dance, gymnastics, yoga, martial arts, hockey goalies, figure skaters. This is an image you saw earlier. So Josh Harris had this study where they looked at a splits position showing subluxation in all of these hips in these dancers. Basically, the subluxation was increased if they had a greater alpha angle and a decreased neck shaft angle. So here's our typical cam. This is not what we're talking about, and arthroscopically, as we evaluate this, we can see sort of this hard stop where there's very limited range of motion. But these patients we're talking about are very different. They tend to have real subtle decreased head neck offset distally. They may have these rim indentations distal on the femoral neck, indicating higher range of motion. And arthroscopically, what you can see is, actually this is the wrong video, I'll show it again, but basically what you can see is at a high range of motion, you'll see this subluxation of the femur, and I will show that again so you'll get to see that. Acetabular sided findings, the AIS impinges against the distal medial neck in flexion. You'll oftentimes see this bruising over the anterior capsule. It's very focal, and that would be consistent with some impingement in the subspine region. So when you think about these impingement regions and range of motion, remember that the AIS contacts the medial distal femoral neck in extreme straight hip flexion along the medial synovial fold, and the rim contacts the lateral distal femoral neck in extreme abduction along the lateral synovial fold. So you need to know where to go when these patients are having issues based on what they do. So I think respecting the capsule and the psoas tendon has been shown to be critical, especially in the setting of instability, iatrogenic instability with unrepaired capsulotomies, and psoas tenotomies have been shown in an increasing number of studies. So what do we do with these patients? Well, on the femur, we want to correct this kind of distal-based impingement against your high range of motion impingement that you see here. So again, here is the first video. Now watch this, and you'll see the hip sort of subluxate as the lateral femur hits against the posterior lateral rim right there. You can see it subluxate out. And then afterward, once we've done our femoral resection, you can see a better range of motion. It stays seated longer, and as Moritz said, there's more rotation, less translation. So this actually gives them some inherent stability by doing your femoral resection. Decompress the AIS or the subspine region. This will help to reduce the levering effect in flexion. And then preserve the labrum. I think, as we know, oftentimes the labrum is somewhat hypertrophic in these unstable hips. You see that hypertrophic labrum on the left. You can see the repair of the labrum on the right. I think preserving the suction seal, but there's also a little bit more of a stabilizing role. If you look at the ligamentum teres on the left, you can see that fraying, again, consistent with an instability or an impingement-induced instability pattern in this hip. And then the capsular repair or plication, I think, is important. And there are all different types of techniques. So we're looking at a left hip here. And I think it's critical in these hips at the end of the procedure to plicate the hip or repair the capsule. For a plication, I simply just remove more capsule. I'm basically kind of checking the tension of the distal limb against the proximal limb. I'll use anywhere from 4 to 5 non-absorbable number 2 sutures in a male and 5 to 6 non-absorbable sutures in a female to preserve or repair the capsule at the end, side to side, or even plicate it by either, again, removing more capsule or by taking bigger bites. And then I simply just reposition my cannula so I don't have to keep switching portals and eventually close my way out of the hip so that I can't see anything any longer as I'm passing my final sutures. So there's very limited data. This is just sort of more of a conceptual article that we wrote with Ira Zaltz and Ashish Bedi, talking about the hyperflexible hip and managing these patients with hip pain. Again, very limited data. This is a study that we published looking at 16 hips. They had geneticist and rheumatology confirmed EDS, a connective tissue disorder. None of them had really dysplastic findings on their radiographs. The majority had some impingement. They all had a capsular plication. We had about 40 months follow-up, and their mean latest Harris hip was much better than I thought it would be. I didn't think these patients would do well at 88.5, and their mean improvement's probably greater than any other group that I've had, which surprised me. I did not think they'd do well. And then currently, or maybe no thanks to a National Hip EDS website, I now have 48 patients with EDS that I've operated on. We're currently following this group. They're very challenging, but I think it just shows that we can manage some soft tissue instability. And then this group here, again, looking at our hyperflexible athletes. So these are 77 hips and competitive dancers that we operated on arthroscopically. The mean lateral center edge angle was 30 degrees, but 19% of them did have some dysplastic features. And if you look at dancers, ballet dancers, generally about 90% have dysplastic features. So this is a select cohort. The modified Harris hip score did improve 24 points. Mean follow-up was 20 months. And 68% returned to their pre-injury level of dance, 22% had to modify dance, and 10% were unable to return. So not all of them get back. We can help some of them, but this is a very challenging group. So what about this? So this is the last part of the talk. I think we need to redefine borderline dysplasia. Do we just go away from dysplasia and talk about instability? But basically some very mild dysplastic instability findings. So my contraindications, as you heard earlier with previous talks, if they have a break in Shenton's line or any lateralization of the femur, that's an absolute contraindication. Relative lateral center edge angle less than 20, a tonus angle greater than 13 degrees. If they have significant anterior or posterior undercoverage, if they have a low volume globally retroverted acetabulum or a low volume acetabulum, those would be relative contraindications for me. If they have excessive femoral anatorsion, I wouldn't consider an arthroscopy alone. In particular, if they have severe gait abnormalities, significant apprehension, I do mine in the lateral position, Ernie talks about his in the prone position, difficulty with prolonged walking and standing. The more disabled they are, I would consider a derotational femoral osteotomy. So how would I decide whether to send somebody for a PAO or consider an arthroscopy? So for me, I would send somebody for a PAO if they have excessive femoral neck anatorsion. A smaller femoral head tends to be more unstable, globally increased range of motion. Severe disability is one of the main things I'm looking for, standing, walking limitations, using a cane. Or if they have global retroversion, a relatively normal LCE, but they have a minimal cam and a retroverted femur, I would send them for an anteverting PAO. I might consider arthroscopy if they have a larger femoral head, cam deformity, more impingement findings with limited range of motion, pain with torsional activities, and global retroversion but with an anteverted femur and a large cam, I might consider an arthroscopy. My approach, avoid excessive traction, they're very sensitive to traction, preserve the labrum, avoid more than any rim decortication, decompress the subspine if necessary. A femoral resection may help to stabilize some of these hips, capsular plication, and don't cut the psoas tendon. So outcomes, the last part. And I think we're all over the board. We're really comparing apples to oranges. Mostly the reports are looking at lateral center edge angle. It's the same in these two hips, but clearly the mechanics in these two hips is very different. So if we look at studies looking at arthroscopy, here's Ben Dome's most recent study, 5-year follow-up, modified Harris hip improves up to 86. He also looked at globally retroverted acetabulum and showed a modified Harris hip improvement from 65 to 81. This is our results. So again, the results weren't great. If we look at our dysplastic cohort, we had 61% good to excellent results and a 32% failure rate. And in our FAI cohort, we had only an 11% failure rate. But this is over a long period of time. If we just look at our group that we did a labor repair and capsular plication, results are a little better with a 73% good to excellent results and 18% failure rates. And our modified Harris hip in the end was 85. Brian Kelly did a very similar study looking at his dysplastic cohort versus FAI. If you look at his dysplastic patients, all of them had a capsular closure or plication. Modified Harris hip improved from 62 to 85, which was very similar to our study, and the FAI cohort improved from 63 to 85, which again is very similar to our study. But if you look at the dates, this is from 2005 to 2013, so early on in our learning curve managing these hips. And if we look at the open studies, basically, right here you can see Ernie Sink's study looking at 27 PAOs with mildly dysplastic hips, and they improved from 58 to 86. Rafael Sierra and global retroversion improved from 58 to 93 with an anteverting PAO, and Professor Siebenrock has shown us better survivorship with a anteverting PAO at 79% versus a rim resection at 23% at 10 years. So in the end, what's the best surgery for mild dysplasia? If we just look at a modified Harris hip, which isn't very good, we're seeing improvements up to 85 or 86. If we're looking at a pelvic osteotomy, not much data, but improvement up to 86. If we look at global retroversion, improvement to 81. If we look here, improvement to 93. So really in the end, I don't know, but I think these are completely different patient populations getting an arthroscopy versus a PAO. So in conclusion, I think caution and a thoughtful approach is required when you're approaching hips with instability or dysplastic features. Combined acetabular and femoral morphology and level of disability and symptoms is probably key, and we need to have positive predictive factors that are much better defined. Soft tissue laxity, hypermobility with adequate osseous stability can be managed arthroscopically, in my opinion, and often, not always, hips with primarily impingement findings might be considered for arthroscopy, whereas those with instability presentation are best managed with corrective osteotomies in very mildly dysplastic hips. Thank you very much.